This is Randy Schell, and I'm making a video cast on the topic Anesthesia Pharmacology. It's part of our keyword review, and it's part one of a three-part series. And these keyword reviews are based upon many years of published American Board of Anesthesia keywords on pharmacology topics. But in 2017, here's what the keywords were. You can see a parentheses after some of these keywords, like B, which stands for basic content, and A, which stands for advanced content. And let's look at a couple of these. MAC, factors affecting. You know that temperature and age and other anesthetic agents can affect MAC. Muscle relaxation and anesthesia agents. We know that our volatile anesthetics potentiate neuromuscular blockade. Neuromuscular blockade and hyperparathyroidism. If calcium levels go up, it can inhibit neuromuscular blockade or get in the way of neuromuscular blockade or require more neuromuscular blocking agents to have the same effect because of that hypercalcemia. Nitrous oxide can get into closed spaces like pneumothoraces and expand them. Pharmacokinetics, first order elimination, what many of our drugs do, and we'll go over that a little bit later. Phase 2 depolarizing blockade, when large doses of succinylcholine are given and the block starts to look like a non-depolarizing block. Renal failure and opioids, usually related to the metabolites that can occur and which ones are safer to administer in patients with renal failure. Termination of succinylcholine block by diffusion away from the postjunctional membrane and acetylcholinesterase chewing it up. SSEP monitoring, how our anesthetics, many of them like our volatile anesthetics, cause the amplitude to go down and longer time for that signal to get through, which is latency. Ventilatory effects on the volatile anesthetics on the respiratory system, that is, and how we pant with low tidal volume and fast respiratory rate. Emergence delirium, how agents like sevoflurane, for example, in young kids can result in emergence delirium, and we're now often making sure, one, that their pain is controlled, but using medications like dexmedetomidine, Precedex, to decrease that emergence delirium. Itching when opioids release histamine like Demerol and morphine do. Postoperative nausea and vomiting. We know that our inhaled agents tend to potentiate postoperative nausea, vomiting, whether it's DES, SIVO, or ISO. Vaporizers, when we move them from sea level up to various altitudes and how it can change the output of those vaporizers. Intraocular gas, sulfur hexafluoride, and contraindications, specifically administration of nitrous oxide and how it can expand that sulfur hexafluoride gas bubble. Local anesthetics, we add epinephrine often. Cocaine is actually a local anesthetic with vasoconstrictive properties. Antagonism poisoning, usually that's based around things like insecticide poisoning or nerve gases which poison the antagonism, raise acetylcholine levels, and cause muscarinic side effects. Some of the diuretics and what they do, where they work, including their electrolyte effects, upregulation of acetylcholine receptors, and neostigmine, some of the side effects. Those were the key words from 2017. There were no gaps in knowledge in 2017. Gaps in knowledge related to pharmacology, that is, are keywords where more than 50% of people missed the topic. So let's go into our keyword review now, part one of three parts. And in part one, we'll talk about local anesthetics and opioids. Part two, we'll talk about IV induction agents and inhaled anesthetics. And in part three, we'll finish inhaled anesthetics, talk about pharmacokinetics, and then finish up with miscellaneous pharmacology topics. So starting with local anesthetic pharmacology, up at the top right is a figure showing that a local anesthetic is a weak base that can exist in an unionized B form as well as an ionized BH plus form. The unionized B form is what crosses lipid membranes, goes inside the nerve cell, and when protonated becomes the BH plus form, which then has its effect at the voltage-gated sodium channel on the inner portion of it and blocks nerve conduction. The local anesthetic potency is related to lipid solubility. That is, the more lipid soluble the local anesthetic, the more potent it is. And tetracaine is more lipid soluble than bupivacaine, than lidocaine, than bupivacaine, and you can line them up like this with their lipid solubility and potency. Tetracaine being the most lipid soluble, therefore being the most potent. And when you're thinking clinically, think about how you use lidocaine in 1 and 2% solutions. What percents do you use of bupivacaine? 16th percent, 8%, quarter percent. So much lower percentages, usually concentration used clinically for the more potent local anesthetics. The onset of local anesthesia is related to the pKa, which is usually ranging a little bit above body pH all the way up to about 9. So 7.6 for Bupivacaine and up to about 8.7 for chloroprocaine. Remember that when pH is equal to pKa, the ratio of the ionized to the unionized is 50%, half of one and half of the other. Now, if the pH is way below the pKa, there's more hydrogen ion around and more of it exists of the local anesthetic in the BH plus form or the ionized form. So if the pKa of Bupivacaine is the closest to the pH of the body, 7.4, that would mean that Bupivacaine, when you inject it, and the pH is 7.4 of the body, almost half of it's ionized, almost half of it is unionized, as opposed to chloroprocaine with a pK of 8.7 and the body pH being much lower than that, 7.4, and a logarithmic scale. You realize that those chloroprocaine molecules, most of them are existing at a BH plus form because the body pH is much lower than the pKa. So why does chloroprocaine have a faster onset than if its pKa is so high? And the answer to that is you're using extremely higher concentration than the other local anesthetics. You're using 2 to 3%, for example, more molecules. So despite its high pKa, it has a fast onset. We can alkalinize a local anesthetic, add bicarbonate to speed the onset, because when you add bicarbonate to a local anesthetic, it increases the percentage of the unionized form, and it crosses lipid membranes, has its effect faster. So bicarbonate added to a local anesthetic is used to speed the onset. Now, if you inject a local anesthetic into an acidic environment like an abscess, you can then realize that that local anesthetic is going to be protonated by the acid, go into the BH plus form, which then doesn't cross lipid membranes very well, and it's going to slow the onset or have a very poor effect. Injecting a local anesthetic into a abscess doesn't work very well, the local anesthetic that is. Let's look at more about the pharmacology of local anesthetics. They're racemic mixtures in general. There's some exceptions. For example, lidocaine is achiral, and there are some local anesthetics that were developed of a single S form, for example, ropivacaine and levobupivacaine. But ropivacaine is the one that we think of clinically mainly. And the reason for that is because the R isomer form tends to be more potent for cardiac sodium channels and therefore more toxicity. So if we can develop it with the S form, maybe less cardiac toxicity, and that is the goal. Vascular tone, when you inject a local anesthetics, they have an inherent vasodilating effect. So if you inject a local anesthetic into tissue, think of the capillaries vasodilating, and we often add epinephrine to constrict them back down and reduce the uptake of the local anesthetic. Now, cocaine is an exception to the other local anesthetics in the fact that it blocks reuptake of norepinephrine, and if you have more norepinephrine around, norepinephrine is a vasoconstrictor. So cocaine has inherent vasoconstricting properties. When it is used in the nose for ENT surgery, it not only provides topical anesthesia, but also vasoconstricts the blood vessels, reducing blood loss during nasal surgery. Epinephrine can prolong local anesthetic effect, and when we add it in the 1 to 200,000 concentration, that is 5 mics per mil. Some potential beneficial effects of adding epinephrine to local anesthetic is, one, it decreases the plasma concentration of the local anesthetic because it is not taken up by blood vessels as much. The local anesthetic tends to last longer in duration and possibly quality of anesthesia, and you can decrease the blood loss during the surgery, during the procedure itself. So injecting a little bit of epinephrine with the local anesthetic vasoconstricts the blood vessels and can prolong the effect of mainly the shorter acting local anesthetics like lidocaine. So when you think of putting a local anesthetic in the epidural space, sometimes we put epinephrine with lidocaine. Rarely do we put epinephrine with, for example, bupivacaine, because the beneficial effects of epinephrine tend to be with prolongation of the shorter acting local anesthetics like lidocaine. Some allergies to local anesthetics. It's rare. It can be a type 1 immunologic reaction, IgE mediated, type 4, but esters are the bad actors as opposed to amides. Esters can be metabolized to PABA, or paraaminobenzoic acid, of which many people tend to be allergic. If you look at the far right table, you can see the amides and the esters listed. The amides have 2 I's in their name. That's one way to remember them. Lidocaine, 2 I's in the name. Bupivacaine, 2 I's in the name. Bupivacaine, these are all amides, while esters have 1 I in the name. Cocaine, procaine, chloroprocaine, and tetracaine. Now, local anesthetics can have preservatives added to them like methylparaben and metabisulfite, which can cause allergic reactions independent of the chemical structure of the local anesthetic itself. But we tend to think of esters being the ones associated with allergies, much more than amides. Rarely is skin testing used to look for local anesthetic allergic reactions. So esters converted to paraaminobenzoic acid. Amides, if they had methylparaben as a preservative, you can have allergic reactions, but otherwise very rarely to amides. Systemic toxicity tends to be more with amides. Why? Because amides are broken down in the liver quite slowly, while esters are broken down in the blood by esterases quite rapidly. Esters can be prolonged in their action and increase the risk of systemic toxicity if you have an abnormal esterase type enzymes, and one of those esterases is acetylcholinesterase. And Dibucaine is one of the things that we'll talk about later, a amide local anesthetic that normally inhibits acetylcholinesterase by about 80%. And if you have an abnormal Dibucaine number, suggesting an abnormal acetylcholinesterase enzyme, you can have prolongation of ester local anesthetics, as well as the main one we talk about is succinylcholine. Amides, if you have a really bad liver, amide systemic toxicity can be increased because the amides aren't being chewed up in the liver as rapidly. And if you inject a local anesthetic and the liver is not metabolizing them, you can see how toxicity would be increased. Now, the site that you inject the local anesthetic or spray the local anesthetic or apply the local anesthetic can be associated with toxicity. If you give it intravenously, obviously the highest levels would occur tracheally. If you spray lidocaine in the airway or benzocaine in the airway, very rapidly absorbed. Intercostal is a classic nerve block with the highest local anesthetic toxicity. The levels get the highest, followed by caudal, paracervical, epidural, brachial plexus, sciatic, and finally by subcutaneous injection. We previously mentioned that potency was associated with lipid solubility. The more lipid soluble, the more potent it tended to be. And the more potent a local anesthetic is, that tends to correlate also with toxicity. The presentation of local anesthetic toxicity tends to be things like early ringing in the ears, circumoral numbness, some twitching, followed by seizures, followed by coma, respiratory arrest, and followed by cardiac toxicity. Local anesthetic toxicity, when it occurs, the treatment is airway, breathing, and circulation, and suppression of seizures. One way to suppress seizures is we have drugs like midazolam right next to us, or propofol, which can stop seizures. Usually we think of midazolam as one of our first choices. If a patient's having a local anesthetic systemic toxicity and is very hypotensive, propofol probably wouldn't be a great choice. So suppression of seizures with benzodiazepines, ventilate and oxygenate the patient, realizing that local anesthetic toxicity is worsened when there's hypoxia, acidosis, or hypercarbia present, And a classic one is pregnancy, where if you get a local anesthetic toxicity, high levels in a pregnant patient, it's worse. Cocaine toxicity is a little bit unique. Cocaine is used in nasal surgery for its vasoconstriction as well as its local anesthetic properties. The maximal dose is about 3 milligrams per kilogram. And because cocaine blocks reuptake of norepinephrine, it has its vasoconstrictive effect. If lots of cocaine is absorbed, you can see how a lot of norepinephrine would be around and the patient would be hypertensive, might have ventricular ectopy and be tachycardic, and even have myocardial ischemia from coronary vasospasm. And the treatment for cocaine toxicity is stop the coronary vasospasm with nitroglycerin. Don't use beta blockers first, even if they're tachycardic and hypertensive. Give nitroglycerin. There are some populations that have a higher chance of having local anesthetic toxicity. That's the very young and the very old, because they don't clear it as well and maybe absorb it a little more and have increased systemic levels. Epi will decrease the absorption of local anesthetics, and it tends to prolong lidocaine, as we said, the shorter acting local anesthetics, more than it does the longer acting local anesthetics like bupivacaine. Sometimes we'll put epinephrine in caudals, and if you do a test dose in a caudal, a very small dose, and have epinephrine in it, systemic toxicity can be detected not only by absorption of the epinephrine into vascular structure and the heart rate going up, but also by peak T waves. And if you have local anesthetic toxicity, it can progress not only from the tachycardia and peak T waves, if you inject a large amount, to severe hypotension, bradycardia, and arrest. And instead of being in the caudal space, you may have been directly intravascular or possibly intraosseous. More on local anesthetic toxicity. The local anesthetics have their effect at sodium channels, blocking them. And there are sodium channels in the heart, in the SA and AV node, and vascular structures. So you can see why a patient who's having local anesthetic toxicity with all their sodium channels being blocked could be hypotensive, have AV block, heart block, and contractility of the heart being reduced. Interestingly, dilantin also acts at sodium channels, and the isomeric forms of local anesthetics vary in their toxicity, with the R isomer being more toxic than the S isomer. Therefore, ropivacaine, which is an S isomer form, would be considered less toxic. Bupivacaine, cardiotoxic, we say, slow into the sodium channel, slow out. If you get a large amount of bupivacaine injected intravascularly, for example, you are going to have real problems with local anesthetic toxicity because it doesn't leave the sodium channel very rapidly. The treatment is establish an airway and hyperventilate the patient. You're going to probably have to have a prolonged resuscitation. You're not going to give up early. And some general principles: lower doses of epinephrine are used in resuscitation from local anesthetic toxicity. The classic dose recommendation being less than 1 mil per kilo or so. And lipid emulsion is the treatment, 20% therapy, 1.5 mils per kilogram, approximately 100 mils as a bolus. That removes the lipid from the plasma and creates a sink for it to be then removed from the sodium channel into the plasma, and speeds the onset of recovery from local anesthetic toxicity. So lipid emulsion, this isn't propofol, this is the true lipid emulsion, is the therapy for last. Of course, if someone has VFib, you're not going to give them lidocaine because your toxicity is occurring because a local anesthetic has been given. Amiodarone can be used if you have resistant VFib. You're going to avoid calcium channel blockers and beta blockers. Their contractility is already reduced. Their AV node is often already blocked. And if it becomes necessary, prolonged resuscitation utilizing cardiopulmonary bypass can be used. The American Society of Anesthesia has published a checklist for treatment of local anesthetic systemic toxicity, and it's listed here on the right. So let's go down through that briefly. Airway management, we said, is important. Ventilate with 100% oxygen and hyperventilate the patient. Suppress the seizures with benzodiazepines like midazolam. Get cardiopulmonary bypass ready, especially if bupivacaine has been the cause of the local anesthetic toxicity. Slow in, slow out to the sodium channels. Begin your ACLS. Get your medications ready, and we're going to avoid medicines like vasopressin, calcium channel blockers, beta blockers, or local anesthetics. We're going to reduce our dose of epinephrine during our ACLS event to less than 1 mic per kilogram boluses. And we're going to get out our lipid emulsion 20% therapy early and give 1.5 mils per kilogram lean body mass over about a minute and start a continuous infusion of the lipid emulsion. The next topic is methemoglobinemia. Methemoglobin is the form of hemoglobin where the iron inside of it has been oxidized from Fe+2 to Fe+3. And methemoglobin doesn't bind oxygen. The graphic on the top right shows methemoglobin in brown, and blood has a brown color when methemoglobinemia occurs, and in red, the Fe+2 form of hemoglobin, which binds oxygen. And the treatment to convert methemoglobin Fe+3 to Fe+2 normal hemoglobin is methylene blue. What local anesthetics can cause this? Prilocaine is the classic one, which has a metabolite, orthotoluidine, which can cause this Fe+3 state of hemoglobin. Where is prilocaine? It is in EMLA cream. It can be in some nerve blocks. Benzocaine also can cause methemoglobinemia if you're spraying up an airway and spray a lot of it and it's absorbed topically, mucosally, and the patient's saturation starts to drop towards 85%, which is classic absorption level of methemoglobin at that SpO2 of 85%, you should think this could be methemoglobinemia. An arterial blood gas sent off and measured on a coaximeter can document levels of decreased oxyhemoglobin and increased amount of methemoglobin. Treatment, if it becomes necessary, is classically methylene blue. However, simply giving oxygen, stopping the administration of whatever the offending agent is, the benzocaine, for example, hyperbaric oxygen occasionally, methylene blue in a treatment dose of 1 to 2 milligrams per kilogram of a 1% solution over about 5 minutes can reduce Fe+3 back to Fe+2. Now there is a contraindication. G6PT deficient, glucose 6-phosphate dehydrogenase deficiency, apparently is quite common in patients of Mediterranean descent, and if you give them methylene blue, it can cause a hemolytic anemia. And so in those patients, if they get methemoglobinemia, there's other things like transfusion of blood and dialysis apparently that can be used to treat it rather than the methylene blue. EMLA cream, what is that? It's a eutectic mixture of 2 local anesthetics, lidocaine and prilocaine being the one that can cause methemoglobinemia. Some side effects of EMLA cream, if you apply it on the skin, it tends to cause skin blanching or whiteness underneath it. Some contraindications. When would you not want to slather someone up with EMLA cream? If the skin is broken, or you're thinking mucous membranes, you're not going to put it there. Infants very young can't metabolize the local anesthetics as well, don't put it on them. And patients with this predisposition to methemoglobinemia, like G6PD deficient patients. EMLA cream, topical anesthesia, 2 local anesthetics, prilocaine being one of those. Transient neurologic symptoms, what are those? Those are classically pain in the buttock area and the low back and the posterior thighs after someone who's had a subarachnoid block, classically with 5% lidocaine, and its onset occurring within 24 hours after they've recovered from that subarachnoid block. TNS, or transient neurologic symptoms, start within 24 hours and recover within a week or 7 days. The association is high with hyperbaric lidocaine, although it's also occurred with other local anesthetics like tetracaine and bupivacaine and others. The incidence tends to be highest in patients who are done as an outpatient, obese, in the lithotomy position with that 5% lidocaine given subarachnoid. These patients will call you up within 24 hours saying, I'm having low back pain, thigh and buttock pain, and you will see them and document that there's no sensory or motor deficits. And if there's no sensory or motor deficits and they don't have a temperature, you say this isn't a hematoma or an abscess. Give them non-steroidal anti-inflammatories, and within 7 days their pain will be gone. The next topic is liposuction and lidocaine toxicity. In liposuction, a large volume infiltration of the fatty tissue is done with a very dilute lidocaine and epinephrine solution. The lidocaine can be so dilute, 0.025 to 0.1%, and the epinephrine, not 1 to 200,000, but 1 to a million. So instead of 1 to 200,000, which has 5 mics per mil of epinephrine, 1 to a million has only 1 mic per mil. You can give quite large doses per kilogram of lidocaine, 35 to 55 milligrams per kilogram. You say, well, wait a second. Subcutaneous injection without epinephrine, we use the toxic dose of 3 to 4 milligrams per kilogram, and with epinephrine, we can give up to 7 milligrams per kilogram, but we can use 35 to 55 milligrams per kilogram in a tumescent solution or infiltration. Why? Well, probably low blood flow to adipose tissue. The epinephrine causes vasoconstriction, reducing absorption. The lidocaine sequesters in the fat, and peak lidocaine levels after tumescent liposuction occur at about 12 to 14 hours after injection. And then they tend to decline over the next 6 to 14 hours or so. So peak lidocaine toxicity you would expect to occur about a half a day after infiltration. They may have signs of local anesthetic toxicity, things like tingling in their tongue, around their lips, ringing in their ears, numbness around their mouth, and they may even become very sedated and have mental status changes. There's a recommendation that you not do large volume aspirant liposuction in an office-based setting, and mortality can occur from liposuction related to not just lidocaine toxicity, but also fat embolism. So if a patient presented, for example, in the recovery room with a fever and hypoxemia and a petechiae on their chest, that would probably be suggestive of fat embolism. PE can occur if a patient is obese and not ambulating. They're at risk for PE. And if you have a sudden drop in end-tidal CO2 and hypotension, think PE. Blood loss can occur with large liposuction. If the blood vessels are disrupted and bleeding can occur, so don't forget about that. But the classic is lidocaine toxicity, and that's about 12 to 14 hours after injection, the highest peak levels occurring. The next topic is placental transfer of local anesthetics, and Bupivacaine being one of those. Remember that local anesthetics can exist in that unionized B form and the ionized B plus form. They are weak bases that are classically bound to alpha-1 acid glycoprotein. So how can they get across the placenta? Well, it depends on the pKa and the maternal and fetal pH and the degree of protein binding of the local anesthetic. But one of the things that we worry about is this concept of ion trapping, and that is if the fetus is not doing very well, that is, it's getting more and more acidotic, possibly from not good blood flow and not enough oxygen, and the acid levels in the fetus are building up, or hydrogen ions building up, the local anesthetic from the mother can cross over in the B form to the child and then become protonated in the BH plus form, and then it's trapped in the fetus and can't get back to the mother, and it builds up. That's called ion trapping, secondary to fetal acidosis. This does not occur with chloroprocaine. Remember that chloroprocaine is the least placental transferred. It's also, being an ester local anesthetic, is rapidly metabolized, and we consider it, quote, safer when fetal distress is present to use as our local anesthetic, for example, in epidurals. There are lower fetal blood levels of bupivacaine than lidocaine, and the reason for that is probably the highly protein-bound nature of bupivacaine. If a local anesthetic is bound to protein in the mother, it has less chance of crossing over into the child. Let's look at a question here. Which of the following statements concerning the cardiovascular effects of bupivacaine and bupivacaine toxicity is true? Does bupivacaine quickly dissociate from cardiac sodium channels? No, it's slow in, slow out. Is cardiovascular toxicity decreased during pregnancy? No, it's increased. If we have SVT with a local anesthetic toxicity, should we use diltiazem to treat the SVT? And we know that that's not a good idea, neither is beta blockers. And systemic vascular resistance, is it decreased? Absolutely, they're vasodilated. Let's move on now to neuromuscular junction physiology and neuromuscular blocking agents. Up at the top right shows a classic neuromuscular junction, and let's follow acetate and choline, which combine together to form acetylcholine. Choline is taken up presynaptically. After it is cleaved, acetylcholine is cleaved into acetate and choline. Choline can be reabsorbed. Acetate's made by metabolism. Acetylcholine is put in little vesicles, and it is ready to release into the junction when a nerve signal comes down. Now, presynaptically is voltage-gated calcium channels. When calcium comes in presynaptically, these little acetylcholine vesicles are released. When the acetylcholine is released into the junction, it crosses over and binds to, at the top right, is the postjunctional receptors, which are made up of 5 little proteins. The 2 alpha subunits being very important, because that's what succinylcholine and the non-depolarizing neuromuscular blocking agents, as well as acetylcholine, bind to. When acetylcholine binds to these alpha subunits, the postjunctional receptor opens up and sodium goes in and potassium goes out, and you have if enough of them open up, a nerve signal that is transmitted. So let's look at calcium presynaptically and its effect on release of acetylcholine first. Magnesium in obstetrics, if someone's getting a magnesium infusion, you can see how magnesium impairs calcium coming in presynaptically, and if you need calcium to cause release of acetylcholine, a patient who's receiving magnesium can be weak and have reduced deep tendon reflexes. Hypocalcemia could potentiate neuromuscular blockade, and conversely, hypercalcemia, such as that could occur with hyperparathyroidism, could make a resistance to neuromuscular blocking agents. That postjunctional acetylcholine receptor, we said, had 5 protein subunits, 2 being the alpha subunits, and that is where neuromuscular blocking agents actually bind. The enzyme to break down acetylcholine is present in the postjunctional receptor, acetylcholinesterase. Clinically, when succinylcholine is administered, it goes intravenously to the postjunctional receptor, binds to the 2 alpha subunits, opens up the channel and causes an open channel block. Fasciculations occur. But how is Sux terminated? It has to diffuse away from the neuromuscular junction and then be chewed up by acetylcholinesterase in the plasma. Train of 4, there's a decreased release of presynaptic acetylcholine with repeated stimulation. You do your 4 little twitches, and if a patient has a neuromuscular blockade that's present, they can have a decreased train of 4. The first twitch is greater than the 4th twitch, and that's due to a decreased release of presynaptic acetylcholine with repeated stimulation. Clinically also, we can have extrajunctional receptors that grow outside of right under the nerve terminal or postjunctional in cases like denervation, upper motor neuron, lower motor neuron injuries, prolonged bed rest, or chronic exposure to neuromuscular blocking agents, or the classic one being burns. Let's look at succinylcholine in detail now. Succinylcholine is 2 molecules of acetylcholine back to back, as demonstrated in the top right graphic. Succinylcholine binds the 2 alpha subunits of the nicotinic cholinergic receptor postjunctionally. This is the same site as non-depolarizers like rocuronium bind to. Sux increases lower esophageal sphincter tone. Remember that when you press on the cricoid cartilage, it actually decreases the lower esophageal sphincter tone. People were worried in the past that if sucks cause fasciculations of the abdominal musculature and raised intra-abdominal pressure, that maybe food would come up and regurgitation would be worsened. But remember that sucks not only causes those fasciculations, but it also causes increased lower esophageal sphincter tone. Dibucaine, an amide local anesthetic, two I's in the name, inhibits butyrylcholinesterase, which is another name for pseudocholinesterase, normally 80%. If it only inhibits the pseudocholinesterase 40 to 60%, that's a heterozygous genetic variant, which is about 1 in 500 people are, and you'll get a little bit longer prolongation of sucks effect, up to about 20 minutes. If Dibucaine inhibits pseudocholinesterase only 20%, that's a Dibucaine number of 20, that's a homozygous variant, which occurs in about 1 in 3,200 people. Succinylcholine, if you give it to them, it's going to last for hours. Now you can wait it out with a patient sedated, for example, with a propofol infusion, and ventilate them artificially until they recover. FFP can occasionally be used, and there's even pseudocholinesterase, lyophilized pseudocholinesterase enzyme that can be given intravenously. So a Dibucaine number of 20 means that you have that variant, homozygous variant, and you're not going to metabolize not only succinylcholine, but ester local anesthetics as well. Don't confuse remifentanil's metabolism with this. Remifentanil is broken down by non-specific esterases, and esmolol is broken down by RBC esterases. So you can also have a problem with the quality of pseudocholinesterase, which is the Dibucaine number issue, or the quantity, where the liver is just not producing enough of the protein, someone with really bad liver disease. Interestingly, obese patients tend to have increased activity of the pseudocholinesterase and resistance, such that we increase the dose of succinylcholine in obese patients because of that increased pseudocholinesterase activity. If you give large doses of succinylcholine, we're talking 4 to 6 milligrams per kilogram, high dose or cumulative doses, or a normal dose in someone with a pseudocholinesterase deficiency, you may get a phase 2 block, which is you give succinylcholine and it looks like a non-depolarizing, like rocuronium block with decreased single twitch, you actually get fade, decreased train of 4, post-tetanic facilitation, and even antagonism with neostigmine, these are all classic features of a non-depolarizing block rather than a depolarizing block. So high dose succinylcholine can cause a phase 2 block. Succinylcholine, it's contraindicated in upper and lower motor neuron diseases, muscular dystrophy, a history of malignant hyperthermia, burns, and diseases of the nervous system that are progressive and active like Guillain-Barré. It's not contraindicated, however, in cerebral palsy, which is a static neurologic disease. So if someone has bad GE reflux who has cerebral palsy and you need to use succinylcholine, it's not contraindicated. It's also not contraindicated in patients with renal failure, but you must remember that succinylcholine raises potassium in the plasma, normally about 0.5 milliequivalents per liter. So if someone with renal failure had a potassium of 6 or 6.5 and it went up to 6.5 or 7, that might be just enough to cause cardiac dysrhythmias. So if the potassium's normal, renal failure is not a contraindication to using succinylcholine. Succinylcholine can raise intraocular pressure slightly and temporarily, and we worry about patients with open eye injuries, that extrusion of the vitreous could occur. However, if you need to use succinylcholine, giving adequate doses of induction agents and providing oxygenation and hyperventilation are things that can block that rise in intraocular pressure. ICP, succinylcholine, it can be raised by succinylcholine, and if RSI is needed, if you give adequate doses of induction agents, again, we will use succinylcholine even with patients with intracranial pressure. However, there's many other options that could be used, like rocuronium, to rapid sequence someone and take this out of the equation. Extrajunctional receptors, these things that grow places that they shouldn't, they proliferate beyond the neuromuscular junction in patients with nerve injuries that are either upper motor neuron or lower motor neuron, strokes, for example, or injuries to like the brachial plexus. Muscle diseases like muscular dystrophy, laying around in bed for a long time, burns. These extrajunctional receptors are a little bit different, and the graphic on the right shows the arrow pointing to a denervated receptor that grows outside the junction. And you can see here it still has its 2 alpha receptor subunits, but it has one different, that gamma unit. And these extrajunctional receptors tend to stay open longer. They release potassium. And if you give succinylcholine to someone, for example, with burns, you know that hyperkalemic arrest can occur. How would you treat it? You would treat it like you would treat hyperkalemia, which is the administration of calcium after making sure you're doing adequate ABCs, airway, breathing, and circulation, alkalinization, hyperventilation, insulin and glucose, and don't forget inhaled beta agonists, which drive potassium into the cell, Alupent or Ventolin being one of those options. Sucks can induce the hyperkalemia, and the causes of such are these upregulated receptors in burn patients, but also don't forget that patients with muscle diseases like muscular dystrophy, if you give them succinylcholine, their muscles can break down and release potassium also. And it is very difficult to resuscitate these patients with rhabdomyolysis, like muscular dystrophy, who are given succinylcholine. Let's look at some diseases now in neuromuscular blockade. Renal failure, pancreatium starts with a P, it's excreted in the P, it's prolonged the longest. Vec and Rock are intermediately prolonged in patients with renal failure, and you know that cisatracurium breaks down spontaneously in a normal pH and temperature dependent state. Spontaneous degradation, that classic Hoffman elimination. And we don't need kidneys or livers to get rid of cisatracurium. So in a patient who has severe liver and kidney disease, and you need to give a paralytic agent, neuromuscular blocking agent, cisatracurium is a reasonable option. Succinylcholine is not contraindicated, as we said, in renal failure, assuming that the potassium level is not high to start with. In the liver disease patient, for example, cirrhosis, again, sucks is not contraindicated because they have a lot of water space. I like to think of the cirrhotic patient as having all that ascites and water in their body, and these neuromuscular blocking agents, being polar molecules or ionized molecules, are going to go to the water space. And you may actually have to increase the dose of succinylcholine because of that volume of distribution. Plasmacholinesterase may be decreased. That is an enzyme that is produced by the liver, the plasmacholinesterase or pseudocholinesterase or butyrylcholinesterase, another name for it. They may result in, when you give succinylcholine, a prolonged block. So bad liver, not producing the enzyme pseudocholinesterase, you give succinylcholine, the block may last longer. The volume of distribution of neuromuscular blocking agents is increased, and the initial dose of either sucks or non-depolarizer may be needed to get the initial effect, but once you give it, it may hang around for longer because liver metabolism clearance is not as good. Cisatracurium would be one example where the clearance would remain the same because it does not depend upon the liver for its clearance. Let's look at some other diseases. Eaton-Lambert, myasthenia gravis versus myotonic dystrophy. Let's look at the top right graphic first of a presynaptic nerve terminal with synaptic vesicles ready to go and be released into the junction and then binding to post-junctional acetylcholine receptors. Eaton-Lambert syndrome involves the calcium channel presynaptically. There's problems with it. And if you don't have calcium coming in normally presynaptically, there's not as much acetylcholine released. Aminoglycoside antibiotics probably act up here near the calcium channel also, while botulism toxin blocks the release of acetylcholine, while myasthenia gravis has antibodies that are destroying the post-junctional receptor. So that's pictorially where the pathology is. Let's look at Eaton-Lambert in detail now. Eaton-Lambert or myasthenic syndrome, often associated with patients with lung cancer, there's decreased presynaptic release of acetylcholine because those calcium channels are messed up. These patients tend to be sensitive to both non-depolarizers, like rocuronium, vecuronium, and pancuronium, but also to succinylcholine. Sensitive to both. While the myasthenia gravis patient has decreased post-junction receptors. They have antibodies against them, destroying those post-junction receptors, and they may be taking pyridostigmine. Pyridostigmine inhibits acetylcholinesterase in an attempt to try to keep the acetylcholine levels up and keep the patient stronger. So a myasthenic patient could be taking the medication pyridostigmine. Another treatment for myasthenia gravis is thymectomy, plasmapheresis to reduce the antibody levels in the patient's body. These patients, they don't have many post-junction receptors, are resistant to succinylcholine, although it's safe to give them succinylcholine. The way I like to think of this is if you don't have many post-junction receptors, remember that succinylcholine needs those post-junction receptors to bind to enough of them, open them up, keep them open, cause the fasciculation and an open channel blockade. So they tend to be resistant, as opposed to the myasthenic patient being sensitive to non-depolarizing. And the way I like to think of that is there's very few post-junction receptors. Now you don't need much rocuronium to compete with those few little receptors left, and you can make them weak very quickly with very small doses of rocuronium. Myotonic dystrophy is an autonomic, dominant genetic transmission. And these patients have a very slow relaxation of muscle contraction. In other words, their muscles stay contracted. And if you give them succinylcholine, it's not a good idea because these muscles all over can contract. And these myotonic contractures can make it very difficult to ventilate them. They tend to be responsive to non-depolarizers in a normal way, but if they have a myotonic contracture, rocuronium, don't expect it to relieve the contracture because rocuronium acts at the neuromuscular junction, post-junctional receptor, while the disease of myotonia is in the muscle itself. So think Eaton-Lambert, presynaptic, myasthenia gravis, post-junctional receptor problem, not enough of them, antibodies destroying them, and myotonic dystrophy being a genetic disease where the muscles don't relax and the disease is in the muscles themselves. Periodic paralysis is the next disease. It's intermittent skeletal muscle weakness that usually spares respiration. So think of a patient who suddenly gets hypokalemic for whatever reason, and then their muscles become very weak. There's some people, if they get hyperkalemic, their muscles can become very weak. This is not a problem at the neuromuscular junction. It's a problem in the muscle membranes themselves, and it's probably the sodium channel that's involved, although there's some suggestions that calcium and potassium channels may also be involved. But we normally think of periodic paralysis as being a sodium channel problem, and that patients who get hypokalemic or hyperkalemic who have this disease can get muscle weakness. Let's look at the hypokalemic periodic paralysis first. What causes low potassium? Well, catecholamines drive potassium into the cell. So stressful situations with high states of catecholamines, you're going to have a lower potassium level. Carbohydrate loads in glucose solutions, if you pour D5W into a patient, their glucose goes up in the body, their insulin kicks in. What does insulin do? It drives potassium into the cell. So giving large amounts of glucose to a patient with this disease would not be wise. Beta agonists, like inhaled Ventolin, will drive potassium into the cell. Epinephrine, another example. Sux and non-depolarizing neuromuscular blockade is okay in the hypokalemic periodic paralysis form. The hyperkalemic periodic paralysis, what things can cause high potassium? Exercise, giving potassium intravenously. Acidosis raises potassium. Remember, alkalosis, low potassium. Just conversely, just the opposite. And you're going to avoid succinylcholine in these hyperkalemic periodic paralysis patients because we know succinylcholine raises potassium temporarily, approximately 0.5, and it could cause paralysis or weakness of these patients. Acetylcholinesterase deficiency or butyrylcholinesterase or plasmacholinesterase deficiency. It can be a qualitative or a quantitative problem with the enzyme. A qualitative problem would be the patient with a Dibucaine number less than 80, where the amide local anesthetic Dibucaine inhibits it, the enzyme, less than 80%. Or it could be a liver not making the protein and there's not as much in the plasma. That would be a quantity problem. Prolongation can occur of several drugs, succinylcholine being the classic one, but ester local anesthetics, and if you had access to mivacurium, it prolongs mivacurium also. But we normally think of succinylcholine and ester local anesthetics in that pseudocholinesterase deficient patient having prolongation of effect. As previously mentioned, remifentanil and esmolol are not dependent on pseudocholinesterase, and their termination of action will not be prolonged in a person with a Dibucaine number less than 80. There are some medications. One's an eye drop, and the other is a chemotherapy agent. Cyclophosphamide, being a chemotherapy agent, inhibits pseudocholinesterase, and ecothiopate eye drops, which are used in glaucoma patients, irreversibly binds to pseudocholinesterase and inactivates it. So if someone with glaucoma was using ecothiopate eye drops and you gave them succinylcholine, they could have a prolonged action from that succinylcholine. And if you have prolonged recovery from succinylcholine, you can ventilate, sedate, wait for recovery, or supply plasmacholinesterase either by FFP or recombinant forms. Burns, hyperkalemic response to succinylcholine can occur within about 2 days after a burn injury and up to 2 years after they're fully recovered from that. And if you have proliferation of these extrajunctional receptors all over the place, and you have a burn more than 30%, classically, if you use drugs like rocuronium, pancuronium, becuronium, the non-depolarizers, they are resistant to neuromuscular blockade. And the way I like to remember that is they have so many receptors all over the place, not just under the postjunctional membrane, that the rocuronium comes in and goes out to all these different receptors and is diluted from its effect at the postjunctional receptor. Here's a question. A 2-year-old boy is administered succinylcholine, develops the following EKG changes. What's the most appropriate therapy? And you look at the EKG and you can see the peak T waves after succinylcholine. You think hyperkalemia. What's the treatment for hyperkalemia? It's calcium of the ones here. Last couple slides, let's talk about the cardiovascular effects of neuromuscular blockade. Pancuronium is vagolytic, can increase the heart rate. Bradycardia can occur with succinylcholine from its muscarinic effect, and when we give succinylcholine to neonates and infants, which have high parasympathetic tone, some people will give atropine with succinylcholine. Adult patients, usually if you give them succinylcholine, we're sympathetic animals, and we can get tachycardic. But if you had to give a second dose, you had difficulty getting an endotracheal tube down and they're recovering from the sucks, give another dose of sucks, you can get bradycardia in an adult. Histamine release can occur with neuromuscular blocking agents. Succinylcholine releases histamine. Atracurium releases histamine, but it has to be a pretty high dose of atracurium, 2 to 3 times the ED95. ED95 being the dose to reduce single twitch height from 100% down to about 5%. And normally the intubating dose of neuromuscular blocking agents is about 2 times the ED95. That's the way it's established. Determine how much it takes to reduce twitch height 95%, and 2 times that is the intubating dose. So if someone asked you what is the ED95 of pancuronium or vecuronium or rocuronium, you'd take the intubating dose, which you remember, and take it in half, and that would be the ED95. Neostigmine, we use it to reverse neuromuscular blockade. It peaks in about 7 minutes by antagonizing acetylcholinesterase, raises acetylcholine levels for about an hour. It's excreted both in the kidney and the liver, about half and half, and this concept of recurrization really isn't much worry because neostigmine's effect is prolonged as well as the effect of the neuromuscular blockade. So recurrization, a patient who you've given neostigmine, they get strong, you send them to the recovery room in this patient with renal failure, for example, and people say, could they get weak later on as the neostigmine is metabolized and the rocuronium is still present? The answer is very unlikely, as neostigmine's effect is prolonged also. Neostigmine not only inhibits acetylcholinesterase, but it also inhibits plasmacholinesterase or pseudocholinesterase, and it can potentiate succinylcholine's effect. So think about this situation. You've just reversed a patient at the end of an operation. You pull the tube, they have a laryngospasm. You can't break the laryngospasm. So you give them succinylcholine, but they had neostigmine given just a couple minutes before. In that situation where neostigmine has been given, neostigmine inhibits pseudocholinesterase. Pseudocholinesterase is necessary to break down succinylcholine. So succinylcholine's effect is prolonged and it's unpredictable, and you may have a very long time till the patient recovers from the succinylcholine that you gave. What about this maximal dose of neostigmine and how much we should give? Most of us will peak out at about 70 per kilo, 70 mics per kilo of neostigmine, or 5 milligrams. We call it a ceiling effect. We don't go over that because excessive neostigmine can actually lead to a depolarizing block, and in an overdose situation, depolarization of that end plate can be like a succinylcholine block and worsen things. So we stop at 5 milligrams total dose in an adult 70 kilogram patient, and we say if they have not recovered at that point and they still have residual neuromuscular blockade, then we should, in the case of pancuronium and vecuronium, probably ventilate and sedate them. In the case of rocuronium, we might want to use Sugammadex to help reverse them as we ventilate and oxygenate them adequately. Some muscarinic side effects of neostigmine is bradycardia, hypersalivation, and bronchoconstriction. If we gave neostigmine alone and raised acetylcholine levels in the muscarinic receptors would be activated, so we give glycopyrrolate or atropine with neostigmine to block the effects, usually glycopyrrolate. Organophosphate poisoning causes the classic sludge findings, sludge being salivation, lacrimation, urination, defecation, GI upset, and emesis. Organophosphate poisoning would be that classic farmer working with insecticides who has bradycardia and is salivating and wheezing all over the place, and you give them atropine to block it. Nerve toxins. Let's look at botulism toxin and tetanus neurotoxin first. Both of these toxins block exocytosis of presynaptic vesicles, acetylcholine. So you say, well, why does botulism then cause muscle weakness and paralysis, but tetanus causes tetanic muscle contraction? And the answer to that is botulism toxin causes presynaptic decreased release of acetylcholine of neuromuscular junction, neuromuscular receptors, and we're paralyzed because of that, while in the case of tetanus neurotoxin, it's blocking inhibitory neurons. So if you block inhibitory neurons, you get excitation, and the muscles contract, and you get tetanic contraction. So the botulism patient's weak, the tetanus neurotoxin causes muscles to contract. Nerve gases and organophosphate insecticides cause similar issues in the fact that nerve gases like sarin gas that can be used in nerve gas warfare, and organophosphates, which are often used in insecticides, inhibit acetylcholinesterase. So if they inhibit acetylcholinesterase, acetylcholine levels go up, and we're going to get the muscarinic side effects of slowing of the heart rate, bronchoconstriction and wheezing, small pupils, urination, defecation, increased bowel activity, and if you get massive amounts, you can get actually muscle paralysis. And the treatment is to block the acetylcholine effects with atropine. It's a competitive muscarinic blocker. Pralidoxime has been used in the past in an attempt to reactivate the acetylcholinesterase by removing the organophosphate compound, but there's newer evidence to suggest that it may not be very effective. Pyridostigmine actually is a reversible cholinesterase inhibitor that acts at the synaptic cleft like neostigmine, and some people will take this who anticipate being exposed to a nerve agent, so in a war zone. But the take-home message from this is that nerve gases and organophosphate insecticides, the treatment for the increased acetylcholine and muscarinic side effects is to block them with atropine. Pharmacodynamics and kinetics. Pharmacokinetics is referring to the neuromuscular blocking getting in and around and out, And renal failure, liver failure, and acetylcholinesterase enzyme problems can mess up our pharmacokinetics. But pharmacodynamics, what things can potentiate neuromuscular blockade? Both non-depolarizers and succinylcholine are potentiated by our inhaled volatile anesthetics, DES, SIVO, and ISO. Tiva, anesthetic, and nitrous don't have that effect. So if you have an anesthetic, volatile anesthetic, and rocuronium being administered, for example, versus a Tiva anesthetic with rocuronium, you're going to use more rocuronium to keep the same level of neuromuscular blockade in that Tiva patient than you are in the DES, SIVO, or ISO patient. Magnesium, administered during OB anesthesia, for example, can potentiate both non-depolarizing and depolarizing neuromuscular blockade. Remember its effect presynaptically at the calcium channel. And some antibiotics have a prejunctional effect probably at that calcium channel also, like aminoglycosides, tetracycline, clindamycin, bacitracin. But the classic drugs that we use, like penicillins and cephalosporins prophylactically in surgery, do not potentiate neuromuscular blockade. Calcium channel blockers, remember calcium presynaptically is needed for release of acetylcholine in patients on calcium channel blockers. It can potentiate neuromuscular blockade. Lithium, used for treatment of bipolar disease, potentiates both non-depolarizers and depolarizers, and also decreases MAC. So that bipolar patient, if you give them rocuronium or succinylcholine, you'd potentiate the effect of those, and you wouldn't need as much volatile anesthetic to keep the patient from moving to incision. If you combine two classes of neuromuscular blocking agents, you can get some weird effects. If you combine rocuronium with vecuronium, they're both steroidal neuromuscular blocking agents. Their names end in rocuronium, steroids. Pancuronium is a steroid, vecuronium is a steroid. Combine two steroids together, you tend to get an additive effect. Well, if you combine two different classes, like the steroid rocuronium with the quaternary molecule cis-atracurium, which is a different molecular structure, benzoisoquinoline is the name for it, very big, bulky, ionized molecule with the rocuronium steroid, you can get a synergistic effect. Onset and recovery, adductor paralysis. If we monitor at the eye versus at the ulnar, when we recover neuromuscular blockade, the ulnar, when we monitor that, that's the one that tells us that we're fully recovered better than does the orbicularis oculi. The diaphragm tends to be resistant, the most resistant to neuromuscular blocking agents, and the last to recover is the adductor paralysis. So if the adductor paralysis has recovered, then we can say the laryngeal muscles are recovered. So monitoring for full reversal and adequacy of recovery, not on the side of a stroke, for example, but on the normal side, would be monitoring the adductor paralysis. Orbicularis oculi, the onset of block is more rapid and recovery occurs sooner, so that if I was monitoring the orbicularis oculi and it came back, but the adductor paralysis wasn't all the way back, we would say there's still residual neuromuscular blockade. So at the wrist for knowing when you have full recovery, at the eye for the onset of blockade as it correlates with the larynx. Recovery, significant weakness can occur at even a train of 4 of less than 0.9. In the past, we used 0.7 or above, that fourth twitch to the first twitch ratio, as saying they were fully recovered. Now we know that impairment in swallowing and even laryngeal aspiration has observed at train of 4 ratios as high as 0.9. If you have head lift, that does not guarantee full train of 4 greater than 0.9. The ability to hold a tongue depressor between your teeth gets pretty close to that 0.9 if you can't pull it out. Of course, if someone's intubated, the tube would be in the way, so that would be pretty difficult to do. So the classic things that we use, like head lift and some respiratory parameters, not so good for getting up to that train of 4 greater than 0.9. And there's some new neuromuscular monitoring twitch monitors that are good for helping us document that. At the graphic at the far right shows a train of 4 where the first twitch is equal to the fourth twitch, as opposed to at the bottom when a non-depolarizing agent is present, the fourth twitch is less than the first twitch, and double burst stimulation makes it a little bit easier because you only have to look at 2 twitches to say, is the first twitch less than the next twitch? And so why do we use double burst stimulation occasionally? Because it's easier to detect fade. Fade can be detected up to a train of 4 range of about 0.5 to 0.6. What causes fade? Residual neuromuscular blockade, but also a phase 2 block where lots of succinylcholine has been given, or a myasthenic patient who you just stress the neuromuscular junction so much that they start to fade. You don't get fade with the myasthenic syndrome patient. Remember, they get stronger as they work the muscle more, or with magnesium or aminoglycosides. So let's finish up here with one question. Which of the following anesthetic agents would be expected to potentiate the effects of rocuronium neuromuscular blockade the most? Would it be an opioid, intravenous induction agent, propofol, nitrous oxide, or DES? It would be DES. The volatile anesthetics potentiate neuromuscular blockade the most. And this ends part 1 of 3 of our Pharmacology Keyword Review 2018, and I hope you have a great day.